All right, I hope you're all caffeinated and carb-loaded, ready for the next panel. So up next we have a panel discussion that's going to be emceed by Dr. Sellati, so I'm going to hand it over to him.
Hello, for those of you that don't know me, I'm Dr. Tim Sellati, a Ph.D. scientist. I'm currently the Chief Scientific Officer for Global Lyme Alliance. Also was privileged to have academic research funding through the Cohen Foundation for collaborative work that I was doing with Brian Fallon at the time, and now Monica Embers has taken over that really exciting project. Today, we're going to have a panel discussion on the ground, in the field, at the bench. Lyme disease, discovery front lines. We're going to have three panelists. Unfortunately, Dr. Brian Schwartz was not able to attend, but John Aucott, a colleague of his at Johns Hopkins, is going to fill in for him. And then also Matteo Danieletto, and then Rick Osfeld. So we'll have them come up one at a time, just as an introduction for the first discussant. Dr. John Aucott's an associate professor at Johns Hopkins School of Medicine and the director of the Johns Hopkins Rheumatology Lyme Disease Research Center. He's published on the incidence and cost of post-treatment Lyme disease syndrome, or PTLDS, using insurance claims data. He works closely with Dr. Schwartz in the Bloomberg School of Public Health, and collaborates at the Geisinger Health System in their electronic health record-based studies and questionnaire-based studies in Pennsylvania.
Here, taking Brian's place. For those of you that know me, you know that's not my background. that's Brian's background, but it's relevant because Brian's done research actually going back to work on tick salivary proteins and has spent years dissecting tick salivary glands before he really became the main collaborator with the Geisinger Health Clinic, which we're going to be talking about in the next two slides. But I thought I'd give you a little intro about how I became involved with the work in the School of Public Health, which is relevant. As you all know, I'm interested in post-treatment Lyme disease syndrome, especially in clinical research with participants in our SLICE study. And about 8 years ago, we were recruiting, maybe 20 or 30 SLICE patients a year. And I was anxious to learn more about post-treatment Lyme disease syndrome. And at the rate of 20 to 30 patients a year at that point, it was going to be a while. And so I went to Jonathan Weiner, who's a colleague of Brian's in the School of Public Health. I said, I'd really like to study post-treatment Lyme disease syndrome, and maybe looking at claims data, because claims data is available. And Jonathan said, oh, sure, we've got a claims database. It has 50 million people in it. So I went from 50 people to 50 million in one day, and studying 50 million people in this claims database was actually quite remarkable. We were able to identify hundreds of thousands of people with post-treatment Lyme disease syndrome, and really showed that you could use administrative claims data to find people in these large databases and create a computer plan to identify not only Lyme disease, but post-treatment Lyme disease syndrome. And that paper by Adrian on the cost of care for Lyme disease and post-treatment Lyme disease came out of that work. So I was sold on claims data. And what we're going to talk about today is Brian's work, which goes beyond claims data. Next slide. Okay. Control here. Okay. There we go. So it goes beyond claims data. So Brian's involved with the Geisinger Health Plan, which is a remarkable opportunity because it has 1.6 million patients and 45 outpatient clinics, hospitals. And so now we're not talking about claims data anymore. We're talking about the entire health record of a integrated healthcare system. So it's quite remarkable because we were doing claims data based on ICD-9 codes and pharmacy codes. Now Brian has access to the entire medical record. And so what we're going to see is this is a huge opportunity to study, in a large geographic area, these claims data, electronic health records going back to 2001. Geisinger already has an environmental health institute on site at the Geisinger campus, and he has collaborators in place there that are already working on these types of things. So it was really a unique opportunity that Brian had and was funded by the Cohen Foundation to do this. You can see the gigantic area that the Geisinger Clinic follows. So it's really, it's one of the three big health systems in Pennsylvania. And as you all know, Pennsylvania now has the most cases of Lyme disease every year on an absolute number. So what Brian and the team has started to do is to look at these electronic health records, and what we've initially started to do is to show again that you can use a computer-assisted program to look at medical records to define cases, define acute Lyme disease, define disseminated Lyme disease, and my part of it is to define post-treatment Lyme disease. So through these records, you can do this, and it's more than just looking at ICD-9 codes. Now you have access to the actual medical record. One of the big criticisms we got with our paper using claims data from the reviewer was, well, did you review the charts to show that these people really had Lyme disease? And my response was, there are 50 million people in this study. You know, I'm not going to review 50 million charts, but actually, Brian can review these charts because he actually has the medical records, and using artificial intelligence and natural language processing, he can actually, quote, read the charts. And so what we're showing is that you can go into these charts and define not only stages of Lyme disease, but post-treatment Lyme disease syndrome by the computer reading the chart. So you tell it what words to look for, and it pulls them out of the electronic medical record system. So this is a huge advantage over just looking at numbers of ICD-9 codes. Now you're actually looking at the charts. And the other great thing about this system is it's not only the electronic medical record of the system, they actually have also characteristics. So this is an environmental health institute. They have geospatial data on all the patients in their system, so you know where they live. Do they live in an urban environment, in a wooded environment, you know, socioeconomic status, all sorts of demographics. So it's you know, clinical data layered on top of environmental data, layered on top of epidemiologic data. So it's an amazing database, and so that's one big part of the study is looking at the database. There's a poster out there, poster number 8, that shows an initial analysis of how to find acute Lyme disease versus disseminated Lyme disease. We have a paper in a second stage of review on that as well. And so that's the first part. The second part is also through the Geisinger Health Plan. We've been working with Anne-Marie Hirsch and Allison Rebman, and looking actually at initially they were qualitative interviews where they were able to pull out from these databases people that looked like they'd had Lyme disease, and Allison and Anne-Marie developed a qualitative interview where they went in and interviewed a subset, obviously a small sub of people, and then from those interviews pulled out key themes that then they developed a questionnaire that's now being used to study. The original pilot phase of that actually has been published, and it actually showed what we had always hypothesized, is that a lot of the people with Lyme disease actually didn't have a smooth initial diagnosis and treatment. We'd always hypothesized that people were kind of misdiagnosis early, and their qualitative interviews pulled out the exact same themes that I've been seeing in my practice over and over again. People misattributed their symptoms to, you know, I just have a cold. They saw a rash, but it wasn't a bullseye, so they said it can't be Lyme disease because it doesn't have the ring within a ring appearance. They went to the urgent care ER and got misdiagnosed. So we were able to pull out from those qualitative interviews the same themes that we see all the time that represent, we think, you know, some of the risk factors for post-treatment Lyme disease syndrome, and now we'll be able to test those risk factors in the large data set as well. So it's really a super opportunity. Brian's a pro at this. He has a very tight relationship with Geisinger. Already have, you know, 1.5 publications done, and it's really an incredible resource for his work. Yeah.
Okay, thank you very much. The next panelist is Dr. Matteo Danieletto. He received his Ph.D. in telecommunication engineering and the master's in computer science engineering. He currently works as a software engineer for the Icahn Medical School of Medicine at Mount Sinai and the Institute of Next Generation Healthcare. And he's also affiliated with the Arnhold Institute for Global Health. Some of the research that he's done applies Atlas platform developed by the Arnhold Institute to build a mapped hotspot model of significant, reliable, and repeatable prediction for tick presence and density in the environment. The model has the goal to provide an approximation for Lyme disease incidence using heterogeneous data as environmental variables, historical data of tick bites, Lyme disease incidence, and field samples of tick collection.
Good morning, everyone. Okay, I will super fast. So I think we are well connected with the previous presentation because here I reported all the Lyme cases in the United States divided by county level resolution. These data are from CDC, and we can see like in 2000, Lyme disease were well localized in northeast of the United States, and after 10 years was spreading below in Pennsylvania, and from Wisconsin was moving in the east side. So we can see like in 16 years we doubled the number of the cases in the United States reported from the CDC. However, multiple studies reported that then the cases per year is around 300,000 new cases per year. We have a huge discrepancy. So what we want to find is like how is spreading the ticks in the United States? What is the key driven for the ticks? We know ticks cannot fly, so we need to monitor the reservoir, like mice or deer. So we have to check the life cycle of the ticks. The question can be like when Lyme disease is going to hit Michigan, Indiana, Illinois, because the second chart on the top right is like how is evolving Lyme cases in these two states, Indiana and Michigan. And the last chart is like how many times people look on Google Red Bull lice. So we can see like every year there is an increase of search on Google, and the number and the peaks are related to summer season or late spring. So the question is how we can monitor, why, what we need to do to search. Is environmental data, are just the ecological data like deers or mice. Here we can see in New York, we were a little bit stable with the number of the cases along the years. However, how the previous panel said, is in Pennsylvania, that is the ranked number one state, we have 11,000 new cases in 2016. There are two ways to monitor ticks. One is the active surveillance, so state pay people to go in on the field and catch ticks, dragging a device, a tool, and catching the ticks on ground. Or checking the deers at different time of the year. Example, in late spring, we can catch the nymph stage of the ticks, and in late summer or in early fall, we can catch adult ticks. Another way to catch, to have an idea how is the ticks moving is to use a passive surveillance. There are multiple services like a Tick Report or a Bay Area Lyme Foundation had a service where you can send a tick and they can analyze the pathogen and which kind of tick. There is Tick Tracker that you can, with your iPhone or with your smartphone, take a picture, and so you can geolocalize where you were when you find the tick. However, all of these services are publicly available. You can find the data easily, and here there are multiple studies where they use they use active surveillance and passive surveillance. There is an interesting study of 6 years ago where they found in Canada the ticks spread in Ottawa 42 kilometers per year, so it's around 20 miles per year. That is a marathon per year, to have an idea. And last July, a paper came out in PLOS ONE where they use passive surveillance to find a new area where ticks weren't present, like in Arizona, close to Phoenix. So it's the top in the bottom of the last chart. But this data again is publicly available. How is to catch? Are accurate this data, because on the top of the slide there is a tick tracker. and you can see that there are ticks reported in the middle of the ocean. So how we know that there are ticks there? One in Ghana, I put myself last week, and I wasn't there. So how can we use this data? So an idea came out a couple of few months ago, and is a partnership with Atlas, with Arnold Institute, that is our home is in this building. And we are developing a platform to integrate diverse health data source or no health data source. So we want to have a single entry point or end point where all the data stream are come in, we can standardize the data, and the scientists can download easily this information. So at a certain point, scientists, they don't have to take care about how I can extract this data. No, already there, and you can download it and develop your model. The Atlas chart is a perfect example of a polymorphism for computer science, where we have a single core software, and we can modify quite easily for each case. Like we have a vector-borne disease, can be tick or malaria in Africa. We can track community health in Central America. So we can really build this platform quite easily for each case. So what we did, so it's like on the top of the slide, there is an example. We have passive surveillance data from the ticks divided by counties in New York State for 2014 and 2016. And we have the heat map about the maximum temperature. On the bottom, we have all the counties sorted by Lyme cases. And on the bottom, this is the time series, so we can see how the seasonality. So if a researcher, a scientist, so the stakeholder, they want to download this data, it's publicly available, and they can download directly from the website. Our kind of mission is the multiplexer, where we have different time series at a different resolution and time point, and we can merge all of them and standardize for you. And this is my last slide. Thanks for my team that I work with Atlas, and thank you.
So the final panelist is Dr. Rick Osfeld. He's a distinguished senior scientist at the Cary Institute of Ecosystem Studies in Millbrook, New York, and also an adjunct professor at Rutgers University and the University of Connecticut. His training was at the University of California, Berkeley, where he got his Ph.D. He's published over 235 peer-reviewed articles, written one book, Lyme Disease, The Ecology of a Complex System, and has co-edited 5 books, as well as an annual series, The Year in Ecology and Conservation Biology. His research focuses on ecological determinants of human risk of exposure to infectious diseases, emphasizing Lyme disease and other tick-borne infections. And together with Dr. Felicia Kiesing, Dr. Ostfeld is leading a multi-year community intervention program, the Tick Project, aimed at reducing the incidence of tick-borne diseases in our communities.
Thank you, Tim. Good morning. I want to try to take a forward-looking approach this morning. And I want to base this on my observation that precision medicine as applied to Lyme disease is predominantly a reactive approach. That once a patient gets sick, we seek the most precise individual-based means of diagnosing and treating the disease. And this is clearly a valid approach and sometimes a very necessary approach. But I want to try to convince you of is that there is another valid approach which we are calling precision environmental medicine of tick-borne disease. And this is proactive because what we're doing is we are seeking the most precise and locally based information to reduce exposure rates in the first place by controlling tick populations. A precision environmental medicine of tick-borne disease needs to address three questions, and that's what I'm going to start to do this morning and hope that this effort might continue. The first is what? What do we deploy to try to control ticks in a precise and locally based way? We know there are plenty of different products, acaricides of various kinds, that can reduce tick populations, that actually are shown to kill ticks, at least in small-scale field trials. Some of them are things that you apply directly into the environment. Others you apply to particular hosts, the host-targeted ones. Some of them are chemical sprays. Others of them are biological agents that might kill ticks. And what we have is kind of a mishmash of information on various products that sometimes do a good job at killing ticks, but rarely, if ever, are shown to reduce them well enough to protect human health against exposure. And one of the reasons for this is that we are not deploying a precise enough, rigorous enough study design to these systems. And I would argue that what we need to do is to borrow from the rigorous scientific methods of clinical trials in which we deploy particular tick control methods in a design that allows, it's a fully factorial design that allows us to ask, for instance, the impact of a rodent-targeted acaricide by itself, the impact of an environmentally deployed acaricide, whether chemical or biological. We need to also understand the combined effects of both of those tick control agents, as well as having placebo controls for all of these. It is only with these fully factorial designs that we are able to understand factor interactions. Do different tick control methods act synergistically? Do they have more than additive effects? Those are the ones that we should be seeking. Or conversely, do they interfere with one another? Those are the ones that we should be avoiding deploying at the same time. We need to know when we should be deploying tick control methods. We know the tick life cycle is highly seasonal, with larvae, nymphs, and adults actively seeking hosts at different times of the year. We know that the vast majority of tick-borne disease cases, at least black-legged tick-borne disease cases, are transmitted by the nymph stage, which is active in the late spring and early summer. So we need to address the question, do we deploy our tick control methods as a pulse just before or during the active phase? Is that the most cost-effective means of doing this? Or should we deploy them as a press, where we are deploying them all year long to get all life stages? Some may be more vulnerable than the nymph stage and might have a better net benefit. We don't know the answer to this yet. We also know that some years are worse than others. Nymph abundance can fluctuate from one year to the next by a factor of 5 to 10 in the same location. And we know that risk is associated with the abundance of infected nymphs that are crawling around in the environment waiting to find you and suck your blood and deliver pathogens into your bloodstream. We should be able to do a better job, more precise job of timing the deployment of our tick control methods to years in which risk is higher. In oak-dominated landscapes of the Northeast, we know that acorn production by our oak trees are a useful leading indicator of the abundance of infected nymphs almost 2 years in advance, because the acorns boost populations of white-footed mice and chipmunks, which are the two main reservoirs. Outside of oak-dominated landscapes, what are the predictors of either population density of the important reservoir hosts, typically rodents, or of the ticks themselves? We don't know that yet. We also know that as the climate is warming, this is based on 25 years now of monitoring data at our study sites, as the climate continues to warm, the peak activity period in the nymph stage ticks is advancing. It's getting earlier in the year by about 2 weeks over a 20-year period. This should help us do a more precise means of deploying tick control agents at the right time when risk is particularly high, and it may be a moving target because the climate will continue to warm. Lastly, we need to know where in the environment we should deploy these things. Lyme disease is thought of, the conventional wisdom is that this is a peri-domestic disease, that exposure happens around the house, in your yard. But there's surprisingly little firm evidence that that's the case, or that entertains alternative hypotheses. So you can hardly see this, but this is simply the title of a paper led by Ilya Fischhoff, a postdoc in my lab, and it says Systematic Review and Meta-Analysis of Tick-Borne Disease Risk Factors in Residential Yards, Neighborhoods, and Beyond. So this is a systematic review in that we used a transparent search string to search all published literature for any case control data on cases of tick-borne disease in which the people with the disease or the controls, the risk factors that were shown to affect their cases of disease or the lack thereof in the controls was identified spatially. And we defined 3 spatial units. One is the residential yard, so that is within the property boundaries of the patient or the control. The neighborhood scale is the next biggest. That is outside the property boundaries, but within 500 meters of the property. And then beyond is beyond that neighborhood, further than 500 meters away from the property boundaries. Again, a bit hard to see. We started with over 1,200 papers. There are, for various reasons that they did not qualify for inclusion in the study, that was whittled down to only 19 papers in which there was case control data and the spatial dimensions were defined in terms of what the risk factors were. Those 19 papers each had quite a number of different factors involved, so there are quite a number of factors that have been assessed in terms of the spatial dimensions of risk. This is just meant for gestalt, so don't worry that you can't see this. This is simply the results of the meta-analysis for the property level, the yard level. And basically, you can't even see this, but there's a vertical line, which is the odds ratio of 1.0. So I'm going to help out a little bit and blow up the top part of that slide. And what I'm showing here is that not checking for ticks and not bathing when you come in out of your yard is associated with an elevated odds ratio that is significantly different from 1.0. So it's a significantly elevated odds ratio. But now I will show you the data for all 3 of these different scales. And again, guiding you, since this is hard to see, at the yard level, what we have is a significantly elevated odds ratio across the board. The odds ratio overall is 2.6. At the highest spatial scale outside the neighborhood, we have an odds ratio of 2. But at the neighborhood level, so this is outside of the individual yard, but within 500 meters of it, we had almost twice as high of an odds ratio. What this means, therefore, is that almost wherever you deploy tick control methods, they will have some impact, but the greatest impact is likely to be at the neighborhood level, outside the individual yard. So just to conclude, I think that precision medicine, that in the more traditional term, if we can call it that, since it seems to be rather young, but I'll call it traditional anyway, this is fast moving, at the level of diagnosis and treatment is critically important, but we now need to deploy some of those highly rigorous, precise, and individual-based or local environment-based methods to controlling ticks in the environment and furthering our efforts towards a precision environmental medicine of tick-borne disease.
So we'll have the panelists field some questions now. This first question is for Matteo, and the question is whether the density of infected ticks is higher on small parcels of land, I assume, versus larger parcels.
Oh, good question. So the density, to be honest, I really don't know, because what we have, the data from the CDC is just at county level. And we can have an idea using passive surveillance data, exploiting the databases I'm from the tick report that is at the zip code level. However, their studies about, okay, this tick has the pathogen, but we don't know if the subject had the Lyme. So at this stage, we have just an idea about at county level. The main can be great using the ICD-9 or the database from the hospitals to have an idea how the density.
Yeah, if I could follow up, and maybe the other panelists could weigh in. So I remember reading a theory of why Lyme is becoming more prevalent, and I read that as a theory, I suppose, that one of the reasons is because suburbia breaks up land into smaller parcels, smaller wooded areas, for example, and that in a small wooded area, there's enough resources to maintain a population of mice, but not enough area to maintain a population of foxes that eat those mice. So you get more mice, and you get more ticks, etc. I wonder if there's any data to support that, or that's just sort of a fantasy.
I can address that. We published a paper about 15 years ago based on a couple years of drag sampling for ticks and then testing them for their infection prevalence with Borrelia burgdorferi, and then calculating the density of infected nymph stage ticks as a metric of our risk of exposure. And we found that the density of infected nymphs was significantly higher in small forest fragments, less than about 2 hectares, as compared to somewhat larger ones, which were up to about 10 hectares or so, if I recall. And since then, there's been quite a bit of work looking at the mechanism that might contribute to that. It's been found similarly in other systems, not always, but in some other studies. And it is the case that sometimes the small mammals, which are important both in infecting the ticks, not just with Borrelia, but with Anaplasma and with Babesia as well, thrive in those kinds of fragmented landscapes because of food subsidies and because of the reduction or loss of their predators. And so we've also published very recently on how foxes and bobcats in particular reduce infection prevalence in the ticks, presumably as a result of regulating populations of the small rodents by predation.
Also, maybe I can add this. I was reading a book about they did an experiment in an island. They removed the deers from there, and they saw a drop of the nymphs. So it's like open the loop, removing the deers, and they had a drop of ticks.
Right.
The next question is for John. Have you looked for factors that negatively correlate with PTLDS?
I mean, the best negative correlation with PTLDS is time to initial treatment of early Lyme disease, actually. This is data that hasn't been published yet, but it looks like, days are important in the initiation of appropriate therapy and act as a negative predictor.
And Rick, you spoke about a literature review. Oh, I'm sorry. Go ahead.
That certainly kind of makes sense. But I was also wondering, since you have the medical charts, is there something useful we can learn about factors that will exacerbate PTLDS and that will, even more interestingly, diminish PTLDS, either symptoms or probability of getting, I don't know, eating spinach, something like that, anything.
So we focused mostly on aspects of the initiation of treatment and diagnosis at the first points. I mean, the thing that actually I'll show in my talk after lunch is that first antibiotic the patient receives is really important. If they get treated early with an appropriate antibiotic, it's protective. And if they get treated with a non-appropriate antibiotic as the first antibiotic they see, it seems to be the one thing that stands out as a big risk factor. We've looked at initiation of steroids in the first few weeks, and that hasn't fallen out as much. We had hypothesized that steroids would also impact it, but that hasn't borne out. It's borne out as been the first antibiotic that the patient gets.
The next question is for Rick. You spoke about literature review of homes and risk for tick-borne disease transmission. Do you have any studies planned to prospectively evaluate this risk?
Yes, and I hope to be able to report on this study next year or the year after at this meeting or elsewhere. We are funded, we're very creative. We call our project the Tick Project, and this is funded by the Cohen Foundation, and it is a neighborhood-based, replicated, double-blind approach using 2 tick control methods that are fully crossed, where we're following up not only on tick abundance as a consequence of the 2 tick control methods, but also encounters with our participants with ticks that they find on themselves or their dogs and cats, and also cases of tick-borne disease that they report, and those that are substantiated by their healthcare providers. So this is a prospective study. We're about partway through. It's a 5-year study, and we hope to be able to unblind and report, at least preliminarily, within the next 6 months or so.
Okay, so as a follow-up question, why is the likelihood of treating the neighborhood areas more important than one's own backyard?
Well, we can hypothesize why. We don't have a firm answer to that. I think there are a couple of possibilities. One is that perhaps we underestimate the degree to which we interact with our neighbors. I don't know. You all should ground truth that yourselves. I mean, perhaps we use more than our own backyards when we are doing outdoor activities of various kinds. Another reason is that if only a single backyard is treated in an ocean of untreated backyards, then the potential for ticks to be imported into that treated backyard constantly by various wildlife seems very high. But if a neighborhood is treated, multiple yards within a localized area, then potentially the influx of ticks and infected ticks from elsewhere could be substantially reduced. Those are at least 2 possibilities.
This is a question for John. Are patients similar to those identified through Geisinger Health qualitative interviews with delayed diagnosis or treatment being enrolled in the SLICE study?
So that data was from the Geisinger study, so that the answer is no, but we enroll those patients into the SLICE studies that I'll be talking about this afternoon. Yeah.
Let's see. So has there been any, this is I guess maybe a little more of an open question, has there been any differences in the biodiversity of Borrelia where there's a higher incidence of Lyme compared to areas where there is less clinical Lyme?
So, I mean, there's data about genotypes of Borrelia that are more inflammatory producing and possibly pathogenic that have an overabundance on the East Coast compared to the upper Midwest. So there is some data on that, but it's limited, and it's in big areas, not in smaller regions. Yeah.
I myself have sort of a follow-on question. Is there any evidence that differences in the RST type of Borrelia is reflected in a clinical presentation of an erythema migrans lesion versus arthritis, carditis, neurological complications?
So the RST classification does identify these more inflammatory producing strains, and Alan Steer's work has shown that those people both have more inflammatory mediators early on, and then in late Lyme arthritis, they are more likely to develop antibiotic refractory late Lyme arthritis. So they do confer a risk even downstream at late Lyme arthritis that identifies the population that doesn't respond well to antibiotics. So that has been worked out for that specific example of late Lyme arthritis.
Another question is whether gender has shown up as a factor in PTLDS.
So the expert's sitting down there, but I'll answer. Alison Redman's work has shown that, for a lot of these kind of illnesses that have this constellation of symptoms, there is a strong female predisposition to that. It doesn't seem to be as strong in PTLDS, but that's an active area that we're looking at. Allison's work has shown that there may even be a difference in antibody formation, where women seem less likely to develop robust IgG responses than men, which again would make sense because there's differences in sex-based differences in immune response. So it's an area that hasn't really been looked into a lot, but we're very interested in it because there's precedent for this in autoimmune diseases where there's a female predisposition. So it's a really important question.
This is a question for Rick. When evaluating infection control with pulse versus press, does that assume that effective controls are short-lived and require constant maintenance? And what about long-term controls that just require one-time deployment?
Right. So the pulse versus press is more referring, conceptually to me, what's more important is the length of time of efficacy, not whether the action that you're taking is a brief one or not. So I would consider a press experiment to be one that perhaps you deploy a long-lasting intervention. So I'm not sure that that's a useful distinction. We don't know very much about this. The companies that would like you to employ them to control ticks on your property would love to charge you as much as they can and have your property be treated for really long periods of time with multiple doses of tick control treatment. We don't know whether 4 or 5 per year are any more effective than 1 per year. We don't know whether targeting the life stage, the nymph stage that is most dangerous to us, is more effective than targeting other stages, which, there's plenty of life history theory that suggests that in these multi-life stage organisms, some are likely to be the population abundance is more likely to be vulnerable to one of those life stages than the others. And in the ecological parlance, it depends on which life stage has the strongest density dependence. So these are studies that we have a theoretical basis for asking these questions, but we have not asked them very effectively in the real world, and I think it would enhance our precision environmental medicine to do so.
So the next question is a little bit long, so bear with me. You encouraged environmental precision medicine to adopt the rigor of clinical trials, yet clinical trials are arguably overly rigid and omit lots of data and information that may be incorporated through Bayesian methods and adaptive sampling designs. Increasingly, clinical trials recognize this and are undergoing a transformation or modernization to incorporate adaptive sampling designs. Do you see opportunities for Lyme disease to bypass some of the historical limitations of clinical trials by designing studies using adaptive sampling methods?
Yeah, I think that's an excellent question. And ecologists who are involved to some degree in asking these questions about environmental control of ticks and tick-borne diseases have been using Bayesian methods and adaptive methodologies for some time. It's not permeated into the Lyme disease literature very far, but I think it should. I think, yes, it's true. I agree with the premise of the question that there are downsides to focusing on rigor at the expense of being adaptive, being flexible, and that there are alternatives. So I'm a believer in combined methodologies. I think we do need a great deal more rigor, though, at the same time, and I would hate to see that get lost. But I think we can be creative in our designs and not just adopt in whole cloth the rigorous methods from clinical trials just because they've been done traditionally.
So you're up again.
Okay.
While nymph density is the leading risk factor and driven by rodents, have you done similar studies into the role of deer, which are the main host of adults and perhaps more responsible for tick spread?
Right. So Matteo mentioned a study in which deer were eliminated from a very small island off the coast of Maine, and the tick population plunged as a consequence. And that has been a very influential study in arguing that deer control should be a feasible method of controlling ticks anywhere. But it's not as applicable as it might seem to mainland situations where most vast majority of Lyme disease occurs, because you can't eliminate the deer, send them to zero, which is what happened on Monhegan Island. Monhegan Island had no other hosts for the adult stage of the tick, like raccoons and skunks and foxes, so you were eliminating the only host for the adult stage. That's not representative of what's possible elsewhere. And the ticks can crowd on the remaining deer. When you reduce deer by 40 or 50%, each of them gets 40 or 50% more ticks on them. So the result is not what you might expect. Deer do play a role in the ecology of Lyme disease. They don't infect the ticks with any of the important human tick-borne pathogens, but they do host the adult stage. They're probably the most important host numerically, and they are capable of spreading the ticks around in the environment. So it's not as though they play no role, but they don't play quite the role that many people have thought based on some of the earlier studies.
And I think one of the final questions is, what do you think is the most important aspect of prevention? Tick checks, PPE, personal protective equipment, acaricides, etc.?
Well, so my postdoc Ilya Fischhoff is conducting a second meta-analysis, which is not a spatial one, and just yesterday he showed me some preliminary data, but they're not ready for prime time yet. So basically, I can't answer that question yet, but he's gone through all the literature, irrespective of where in space these risk factors occur, to determine through this meta-analytic approach what are the methods that are most effective at reducing Lyme disease, and a second analysis, encounters with ticks. So stay tuned. That's all I can say right now. There are some from the spatial analysis, like doing tick checks and bathing when you come in out of your yard. Those were more effective than most others. But across the board, we'll have that done. He works fast, so we'll have it done in another few weeks or a month.
Okay, are there any follow-up questions for any of the panelists? Oh, I didn't see it come up. Do you want to grab a microphone? Or? Oh, sure.
It's a little beyond my pay grade, but I'll take a shot at it. I mean, one of the problems with clinical trials is, by definition, you try to select a group of patients to study, and you try to get as homogeneous and well-defined a patient population as you can, but the more you do that, the more you limit your generalizability to the main population. I think that's a lot of problems with the Lyme treatment trials of erythema migrans. They're very focused, they're classic designs. You enroll people with erythema migrans only, and you treat and then see what happens compared to other drugs. But that leaves out all the people that don't have an erythema migrans rash, and it certainly leaves out all the people that are presenting with later stages. That kind of second stage is a little more nebulous. So, on one hand, it's a good study design, but it limits its generalizability. And that's what we're kind of worried about as we're thinking about future trials is, we want to get a good, well-defined population, but we don't want it only generalizable to people that have perfect early diagnosis, because that's not the way most people are diagnosed and treated. So it kind of rubs both ways. Yeah.
You spoke about tick reduction. What do you know about tick research to block tick's ability to transmit pathogens? And I wonder if you would please talk about the lack of funding for tick research and what that has meant.
So I don't know that much about methods that might be deployed in a practical way to reduce the transmission of tick-borne pathogens. I know that tick microbiomes. There are other members of the microbial community inside ticks that can influence the probability that an infected tick will transmit the zoonotic pathogen like Borrelia or Babesia. Whether that's manipulable is something that I don't know very much about. The other question about funding, I think, I've criticized the lack of rigor in prior studies of tick control, and I don't think that's because the scientists who are out there trying to control ticks are somehow unimaginative or don't work very hard. I think it's because they can't fund their ideas to do studies at scale, at the right size, with the right replication, with the use of placebo controls, with large populations, large areas under focus. And so I do think that increased funding could have an enormous impact on our ability to reduce exposure rates.
I think in that regard, the Stephen and Alexandra Cohen Foundation and other nonprofit organizations that are funding Lyme and other tick-borne disease research is just incredibly, incredibly important and helpful, because it really does fill a gap in terms of what the scientific and the medical research community is able to accomplish in answering some of these really important questions. Oftentimes there isn't a sufficient amount of preliminary data to really entice the National Institutes of Health, NIAID, or other organizations to try and fund this type of research. So it's a very important role that the nonprofits are playing in providing seed funding to investigators to answer those very tantalizing questions.